for the day, Dr. Shimmy Purushothaman sir, the convener for this program, Dr. Gopi Mohan, the speaker for the day, Dr. Jijo, and all senior colleagues and dear house surgeons who have joined today us on this platform. Today we have a very important topic and very commonly seen scenario. So actually this program is totally designed in such a way to benefit the house surgeons of our state to the maximum. So this program was envisaged by our dear president, Dr. Shimmy sir, in his presidential action plan, and we have already completed 9 sessions on this Zoom platform. I would like to invite Shimmy sir to address the gathering. Thank you.
Thank you, Chairman of the meeting, Dr. Johnny, convener, Dr. Gopi Mohan, the faculty for the day, Dr. Jijo Purushothaman sir, and all those who have joined us today on this platform. Yes, I'm quite happy that our tips for in office practice for the house surgeons is going in a good way. We have covered many of the topics, and we had one out of academics, one financial talk. Actually, we were even planning for a medico-legal talk that we have to see how it works out. If possible, we'll try to have it by the end of October or in November. We'll just see as per possibility, whichever possible, we'll try to do it. But I'd like to all through this and also Jijo today's speaker program ought to be done, and I think so based on that we were continuing. So we are lucky that we have him as a speaker today, and of course Purushothaman sir is there, another teacher who can really guide and give us ideas on how it should be done, and wishing each and every one of you a happy learning. Jai AP, Jai Hind. Over to Dr. Govi.
Thank you, Shimi. Now I request Dr. Binu Kutel, pediatrician from Sanjeevani Hospital, to introduce our speaker, Dr. Jijo.
Oh, thank you, Dr. Gopi. Actually, I'm happy to introduce Dr. Jijo, my close friend. Jijo did his MD Pediatrics from and a fellowship in pediatric respiratory disease and a diploma in allergy and asthma. He's the Dean of Research at Believers Church Medical College. Currently, the Professor and HOD of Department of Pediatrics, Believers Church. And he's in charge of Pediatric Allergy and Respiratory Clinic. He was an executive board member of IAP Respiratory Chapter South Zone in 2022 to 23. State convener of Pediatric Allergy and Applied Immunology Chapter. State convener of Kerala Respiratory Chapter. President Indian Academy of Pediatrics, Pathanamthitta District 2021-22. Published various articles. Editor of the book of Essentials of Pediatric Allergy and Applied Immunology. Very good orator. One of the star cricket players of pediatric team, and a very good organizer also. So I'm happy to introduce Dr. Jijo. Over to you, Dr. Jijo.
Thank you, Binu, for that warm welcome, and thank you, Shimu sir, for taking up this program. Many times interns find it difficult to join the program on time, but we are sure once we share the videos, they will be able to go through it after their regular shifts. I'm very happy Purushothaman sir is there. It makes my work easy because I can give all my doubts to sir. It becomes clarifying doubts becomes very easy for me. So I'll start off with the talk. If there is a delay in the voice or break in the audio or the video, kindly let me know so that I'll switch off the video. I hope the slides are visible. We'll try to go a little slow, and though some slides are in detail, we will go through them briefly. Hopefully, many of the slides will pause for a second so that screenshots can be taken for references later. Now, coming to the topic, we will go in two different ways. The first one is a general approach to any sick child who comes to the ER. I'm sure it has been discussed multiple times across all the talks. We will just brush up, and then we will go into envenomation in general, the general approach to all poisons, and few of the common poisons which we encounter in our regular practice, which house surgeons should know how to give the emergency management and how the course usually is. So the general approach, it is A, B, C, D, E, and the pediatric assessment triangle is something you can very well use in all scenarios when you're encountering a child in the emergency. The very first thing a pediatrician is going to ask an intern or a house surgeon or a junior doctor or a CMO is the child sick? Is it a sick child or a well child? So to know whether the child is sick, these are the three things which you should look into. How is the tone of the child? Is it an interactive child? Is it an irritable child? Is he consolable though crying? How is his look? How is he playful? Coming to work or breathing? We are clear about all those things. And in circulation, how is the is there pallor, mottling, or even cyanosis? How is the pulse volume? These are all the things which we will be worried about anytime a child comes to the ED. Based on your assessment, you can do a focused history under the following headings. One will be signs and symptoms, past medical history, allergies, and medications. Now, as house surgeons, you will become very clear now. Apart from how you are supposed to take a history in your exams and present, when it comes to handling an ED, what you need to focus more is a focused history, giving importance to relevant points rather than going a very wide history, which is expected in an exam. Based on your history, which will have signs and symptoms, head to toe, the child should be looked for consciousness, fever, breathing, appetite. Based on that, you look to take relevant past medical history, look for allergies, and finally medication. What medication is a child taking? Could this child have taken any inappropriate medication or substance? So always suspect envenomation when the child's history and the examination doesn't fit. At all points, at all ages, poisoning should be suspected willingly or unwillingly also. Once you evaluate the child based on the severity and type of problem in the three headings, which will be respiratory, cardiovascular, and also neurological. Accordingly, you will have to do the interventions for airway and breathing, positioning, suctioning, oxygen, or advanced airway. For circulation, IV access, fluid boluses, and for neurology, mainly control the seizures and also manage raised ICT. Now, irrespective what poison the child has consumed, your major aim is going to make sure these things are done right. Only then are you going to go forward with all the complication you are expecting with the poison per se. So let's look about poisoning in general. The general algorithm which we talked about earlier applies here also, following which you recognize the problem, resuscitate the child, removal of poison from the child. We'll talk about these things later in the coming slides. Do a focus, history, and examination. Apply a toxidrome. Toxidrome means a constellation of symptoms which are and signs which are particular of a typical type of poison. We'll go in detail of that also. What are the common monitoring which you're supposed to do? Always make sure an MLC is made even though the poisoning is accidental. Legality, we have to be clear, documented, and an MLC should be made. Education becomes a part usually at the time of discharge. So education in an ED rarely happens unless the patient has come with a minor poisoning, in which you can observe the child or send them back with detailed instruction. So these are things which you should look out for and come back if these signs are there. In that point, always make sure you educate the child. A child who has taken poison by mistake, or a child who has opened a bottle and drank a particular medicine by mistake, is likely to repeat it in the future also. So the education will have to keep away all these things under lock and key, to keep away in stabled bottles away from the child's access. That's a basic thing which you will have to advise. Now, what is removal of poison? One is the child comes with contaminated clothes. If the clothes smell of a particular poison, remove it completely, wipe the child completely down, and wash the child. Triple wash: water, soap, and more water. Wash the child completely. If there is a history of poison going to the eyes, saline wash is what is recommended, and cavities can be irrigated also with saline. A targeted history can be one which is having a witnessed incident of poison being taken, wherein you will take the history, what is the child's age and the weight of the child. What is the poison name and what's the concentration and the amount the child has taken. Concentration becomes very important because, as we very well know, paracetamol syrup comes in different concentration. There is paracetamol drops, which is 100 mg per ml. There's paracetamol syrup, which is 100 or 125 mg per ml per 5 ml. There's paracetamol syrup, which is 250 mg per 5 ml. And also there is currently in the market something called P500, which will be 500 mg in 5 ml. So even though everything is the same chemical, they can be of different concentration. So the same amount will give different levels of drugs to the child. When did the child consume? When becomes very important, because many times if the child reaches the hospital within 1 hour of consumption, many of the gastric wash, charcoal, all those things becomes more effective. The final thing is going to be why. Was it accidental or was it intentional? Accordingly, it matters because the history also depends on how it has happened. Now, if it is unwitnessed, you can use the synonym of would. Would is where. Second one is odor. Do you have the classical garlic odor of that you see in your OPC poisoning? Is there any other victim? For example, this happened in the school. We had a mass poisoning which happened in the school where the children went to after swimming, they went to the restrooms to take a wash, and the whole area was chlorinated to clean the water, and all of them had chlorine poisoning, and they came to us. So that becomes history. Other victims also becomes important when in cases of food poisoning. All those things can be looked into. Drugs in proximity, which are the likely drugs the child could have taken. What all drugs are there at home? What all things are there at home? What all are you sure the amount which is left in the strip is correct as per what the mother or the father takes for that particular medicine? So these are all typical history which you will have to take. Now, if you take one slide for the whole talk and not listen to the talk at all, just take a screenshot of this one slide. Because at the end of the day, this is what I myself do in practice. Even though we try to accumulate the knowledge and keep ourselves revised, the moment we have a child who's been consuming any poison after taking a detailed history, the first thing which we do is call up one of these numbers. They are available round the clock. They will give you relevant information regarding that so that you can start off with your treatment and you're clear as to what should be the ones we should be observing. So this is something which we keep ready in all our groups. So toxidromes is what we spoke about earlier, which is a constellation of clinical signs and symptoms which clearly tell you what poison the patient has taken. You have your cholinergic toxidrome and also you have anticholinergic toxidrome. These are all different synonyms which we can use, which is classical of how the patient behaves. I'm sure every pediatrician over here has seen at least a case of OP poisoning, and they will never forget it because the presentation is quite classical. This is again a slide which you can take a picture, wherein this is about how the child presents and which all are the common ones: anticholinergic ones, the cholinergic ones, hallucinogens, opioid, sedatives, hypnotic, serotonin syndrome, and even the sympathomimetic ones. So these are divided into vital signs, mental status, pupils, and which are the drugs which are commonly seen in this. The first one, the common one which we get is antihistamines taken accidentally. Second one, cholinergic, which we get is organophosphorus, where you have the classical sludge, which is salivation, lacrimation, diarrhea, GA upset, and emesis. Basically, the patient is leaking everywhere, wherever it is possible, which is common with your pesticides. Hallucinogen is little less in smaller children. Opioid, again, is also usually it is in children by accident. Barbiturates or alcohol also can happen with accident. Dextromethorphan is something many times children do drink it. And the last one is also pseudoephedrine also can be part of cough syrups and syrups which a child will accidentally take. These are all the common things which we get. Now, coming to specific decontamination procedures, one is gastric lavage. Ideally, should be done if the patient presents within 1 hour of ingestion. Now, contraindications are decreased consciousness. If the patient has taken a corrosive, which is either an acid or an alkali or a volatile hydrocarbon, you should not be doing a gastric lavage or putting an NG tube. Now, the technique, all of you are clear how to put an NG tube. Check your position, keep the patient left lateral, and give 10 ml per kg saline aliquots till whatever you're getting back as return is completely clear. Coming to activated charcoals, when you're going to do a night call in a different hospital, make sure activated charcoal is available. It is cheap, but availability is of great importance. because if it is there, it can definitely save lives across different ages. So it acts as an enteral dialysis. Ideal benefit is max within the first 1 hour of ingestion. 1 gram per kg is the dose. We usually mix it with water or juice in 1:4 or 1:8 to make a slurry, and it is given orally if the patient can take it. Most of the times it's given through the NG. It is what you see in all the poison patients where they have an NG and they have something black in it. What is it not useful for? Pesticides, hydrocarbon, alcohol, iron, and even lithium solvent. Whole bowel irrigation is indicated in iron, enteric-coated capsules, seeds, and lithium, but always watch for electrolyte imbalance. The dosage is going to be 10 ml per kg per hour for 4 to 6 hours till the rectal effluents are completely clear. You can use PEG. Now, acid is commonly available throughout, and through an NG tube, you can give PEG, which will be easier to intake rather than drinking it directly. Again, I would say taking a screenshot will be better. These are the toxins and the antidote. More that they can be used. They can even be asked as an MCQ questions. For iron, desferoxamine. Cholinergics, you have retropin, opiate naloxone, warfarin, vitamin K, and even INS, pyridoxine. Methemoglobinemia is something which we get because of multiple reasons. We have had cases in different hospitals where we worked, where during holy season, they play with colors, and the colors had chemicals in it, which cause the patient to have methemoglobinemia and methylene blue. So you can have different triggers. Now we'll talk a little bit about the common poisons which we encounter, of which we should all be aware about. You have your kerosene, you have your naphthalene, the corrosive injections, camphor, OPC poison, paracetamol, iron, and alcohol. One of the few of the common things which we encounter, which have not included, include thyroid medication, which the children do take them. But thyroid medications are usually, even unless it is an extremely high dose, it doesn't cause much harm. That is one. The second thing which we do find is good night liquids. All those comes in the discussion which we are going to have in the coming slides. Coming to the first one, kerosene is one of the commonest one. Many a time children mistake it because it is kept in bottles which are meant for soft drinks and carrying water, and children tend to drink it thinking it is water. So it can have GI effects, CNS effects. Commonest one which we are worried about is chemical pneumonitis, which usually takes around 6 hours to present, which is why X-ray is usually delayed unless the patient is showing respiratory symptoms. We wait for around 6 to 8 hours after ingestion for the X-ray to look for chemical pneumonitis. Risk factor for mortality includes altered sensorium, recurrent seizures, and a ventilator requirement. Fatal dose can be as low as 30 ml. The immediate fatal period is the 24 hours after ingestion. So gastric lavage, remember, is contraindicated. Maintain your ABCs, decontamination, remove the clothes, clean the child, because absorption can happen from if it is present on the child's, because it's volatile, from the shirts, from what the child is wearing, absorption can continue. Oxygen administration will replace the kerosene vapors in the lung, so oxygen administration is recommended. Antibiotics not routinely recommended. There are only few case reports of surfactant. Chest X-ray is not routinely mandated. We do it if the patient is symptomatic after 6 to 8 hours. Now, naphthalene is something which can cause methemoglobinemia, which is your naphthalene ball. Fatal dose is more than just one ball. The time period which the child has to be observed includes 2 to 3 days. Management is stomach wash if it will come in immediately. Similarly, activated charcoal. They do advise to avoid fatty foods for 2 to 3 hours, and supportive care based upon methemoglobinemia. You will have to give a blood transfusion, anticonvulsant, and even a steroid to prevent hemolysis. Coming to corrosive injections, alkali, acid, and bleaches. Now, alkali, what we commonly see are the ones used in cleaners if the child takes it accidentally, mostly household cleaners with ammonia. And now the soap liquids is something which you can get. Acid is something which we get in Kerala because of the rubber estates. Many times children have access to acid which is used for rubber sheets. Otherwise, it is a toilet bowl cleaner or a swimming pool cleaner. Bleaches is again usually it comes part of your solutions which they use to bleaching clothes also. In general, they usually cause burn. But depending upon how excessive the burning is, the symptomatology will be seen. In GI, you can have severe pain of the lips, mouth, and throat, excessive salivation, and signs of GI. Respiratory cough, dyspnea, pulmonary edema. Eyes can also have burning sensation, and depending upon the extent, similar presentations can be seen. Important is maintain your ABC. Asymptomatic patient, ingestion is small. All you need to do is observe. If there are signs, you will have to go in for an early airway, definitive airway, because the edema might set in later. The child might look now. Once the burns start swelling up, the patient can go into distress early. So if you feel the child is getting worse, these children will have to be intubated quite early. We have had a child who accidentally had an intake of even a lithium battery which got stuck, and because of the burning happened later, the child's esophagus got burned, and even the artery behind also got burned, and the child had to be taken off for an immediate surgery. GI endoscopy becomes important, but the timing is what you should think about is 12 to 24 hours of corrosive ingestion. Even in those patients who require an NG later, they are all put directly with endoscopy under observation only. These patients, if they survive, also has a high chance of having strictures which can cause problems later. Camphor is what we see as for typically used in all our puja. Right now, there are a lot of pujas happening across the country. That is one. The second thing where children get access for is all our topical decongestants, which is usually seen at the bedside table, which includes your Vicks, Tiger Balm, and all of things. Toxic ingestion is more than 1 gram. Nausea, vomiting, and headache. You can make out with the classic smell many a times. Children can have seizures also. Those seizures are not dose related, but happens quite fast. So usually they will have seizures within half an hour of ingestion. Neurotoxic dose is more than 50 milligram per kg, and a fatal dose is more than 500 mg per kg. Management, decontamination of the skin and GI, treat the seizures and other epileptics as per how you will manage a status epilepticus. A class for that has been taken earlier. OPC poisoning is the most frequent used for pesticide worldwide. One of the highest amount of poisoning which happens across the world is OPC poisoning, knowingly or unknowingly, mainly because of access to these things, because of farming and other different types of OPCs available in most of the houses. So they can classically have the sludge which we talked about, which is diaphoresis, diarrhea, urination. You lose fluids through every orifice possible. Meiosis, bradycardia, bronchospasm, emesis, lacrimation, and salivation. The nicotinic effects include fasciculation, cramps, weakness, reflexia, paralysis. Sympathetic ganglia includes tachycardia, hypertension. CNS will have agitation, ataxia, weakness, and even seizures. But remember, when it comes to children, they are more likely to present with altered sensorium than the classical muscarinic features which we see. But do look into the eyes of the children. Look at the pinpoint pupil. Meiosis and mydriasis definitely helps you out. Now, this classification which you can use based on the plasma cholinesterase level, mild, moderate, and severe. Accordingly, the similar signs and symptoms also will vary. Quick severity assessment when you come see a patient. For a patient who's there in the ED, it is mild if it's walking, headache, abdominal pain, and vomiting. It is moderate if he's conscious but anxious, restless, meiosis has settled and cannot walk, and child speaks with a soft voice, and severe if there are no pupillary reflex, pinpoint pupils, convulsions, flaccid paralysis, and even respiratory failure. Maintain your ABCDE, decontaminate the patient, bathe him, give a gastric lavage, start atropinizing as early as possible. You keep atropinizing. You don't have to worry about what is the higher dose, 0.05 mg per kg every 10 minutes. Keep on giving fluids unless the secretions become dry. Signs of atropinization include skin and pupillary dilatation, tachycardia. Of these things, usually what we look out for is tachycardia and pupillary dilatation. These are two things which you should keep repeating, keep looking, and you keep atropinizing the child as much as possible. The antidote comes in, which is your pralidoxime, which is available. Again, it has to be given at a dose of 50 mg, 25 to 50 mg per kg over 1 hour and repeated every 8th hourly, or can even be put as an infusion also, but it is useful in carbamide. So as soon as the patient comes in, start treatment with atropine, start pralidoxime. In the meantime, find out the content, talk with your local toxicology the department or the center number which I've given, and start giving specific treatment. In the meantime, any which way the pediatrician will get involved. The contraindicated drugs include aminophylline and also aminoglycosides amongst the one which we usually use. Delayed effects can come later also. So patient can have a delayed effect which can be after 1 to 4 days, which can include head lag, cranial nerve palsies, and even they rarely have muscarinic symptoms, but the treatment remains supportive till the drug is completely cleared of the patient. Delayed can happen up to 2 to 3 weeks with persistent CNS symptoms, and recovery can take up to 12 months or even 1 year, and at many times it can even be incomplete also. So distal muscle weakness with relative sparing of neck muscles, cranial nerve, and proximal muscle groups are also possible. Coming to paracetamol poisoning, as we talked earlier, it is highly likely in children. Most of the times it is accidental because of different strengths of paracetamol available in the market. India is one of the only few countries across the world where you have different strengths of paracetamol under the same headings, and it's very easy for the patient to make a mistake. The mistakes can even happen at the pharmacy level also when they can issue a wrong medicine having a similar name. So what is important is the dose the child has taken. The moment the dosage is more than 150 milligram per kg, that is for a 10 kg child, if he takes 1.5 grams of paracetamol in 24 hours, the child is having the dosage is quite high. It is suggestive of paracetamol poisoning. You look at in the clinical phases as 1, 2, 3, and 4. The 1 is what the patient is going to present to you in your ED with a classical history of taking paracetamol, nausea, vomiting, abdominal pain, and labs are usually normal. But what do we do after these children get admitted? The next 24 to 72 hours, we look at the child's whether the symptoms are subsiding. We look for lab evidence of deteriorating LFT, falling bicarb and raising creat. A hepatorenal syndrome can happen. These children can have hepatic failure, which usually sets in by day 3, wherein the GI features reappear with features of hepatic failure, hyperammonemia, and hypoglycemia, and the death can happen because of hepatic or renal failure. Thanks to these symptoms nowadays, many parents do commend us, can we give paracetamol for our children? Isn't it toxic? So the point being is paracetamol in the right dose is fine, but when you can overdose it, അധികമായാൽ അമൃതം വിഷം അതാണ് paracetamol. So the side effects are known, the profile is known, so accordingly you have to pick up the patient. And what do we do when we get it? You monitor serum paracetamol level at 4 hours, decontamination, elimination, gastric lavage and charcoal if it is early. Above everything else, specific antidote of N-acetylcysteine is what is going to play the role. So if the patient has more than 150 milligram per kg, you start away NAC even before any of the other reports come. You're allowed to err high in such conditions. So this is when you have the levels, which at this point is available only with Amrita. So what we do is we start NAC quite early, and based upon how the child is behaving, we stop it and continue with the rest of the supporting measures. There are different methodology which you can start. The second part is easier, wherein you load 150 milligram per kg of NAC over 60 minutes as an infusion, following which you give a maintenance infusion of 15 milligram per kg per hour. It is continued until serum paracetamol concentration is 10 milligram per liter. All the liver enzymes is showing a normal trend or a lowering trend. Usually 24 to 48 hours NAC is continued is what we regularly see. Next one is going to be iron. Iron, more than the syrup, what we commonly see is the children taking the tablet, the capsules accidentally because they are quite colorful, and they tend to mistake it for gems because the syrup is a little bit difficult to drink, so it's not so easy. But it does happen sometimes. There are some syrups which are of higher concentration. For example, Tonofer is one of the brands which has a much more higher concentration than other brands. So it's very easy for a smaller child to have a toxic dose of the same with a small volume also. So again, they are available as drops and syrups of the same name with differing concentration, which also can lead to errors. So the initial phase will have GI symptoms. Phase 2 will have latency, where there is partial clinical improvement. Phase 3 is systemic symptoms, toxicity, which appears by around 24 to 48 hours, and hepatic failure sets in by day 2 to 4 days. And finally, it is late complications, which comes in as late as 2 months, including GI strictures. Management is supportive. Decontamination of whole bowel irrigation is recommended. Charcoal and lavage may not be useful. Ceramide at the end of 6 hours post injection can be done. Based on the iron, you can may do correlate with clinical severity, wherein mild is less than 300 microgram, moderate is 300 to 500, and severe severity is usually seen with levels of more than 500 microgram. IV ranitidine and hemodialysis at times will have to be attempted if required as per the child's condition. When do we start an antidote? If the consumption is more than 60 milligram per kg, that means for a 10 kg child, if the child takes more than 600 milligram, if the child has severe symptoms, high WBC, RBC stays high, serum iron levels are high, and the child has a high anion gap metabolic acidosis. Now, general rule of thumb, if you are not able to remember or you can't access somebody over the phone, what investigations to send, always send an LFT, an RFT, electrolytes, calcium, and also a VBG before starting treatment for any child who comes up with poison. This is a general concept, even if you're not sure. A CBC also will help you. So these are things which you should do, irrespective when you're not clear as to what specific investigation has to be done. Then based on it, accordingly you can do. Another general thing which we always say is whenever you're giving a gastric lavage, you should keep one as an evidence and send one for analysis of what poison the child could have taken, especially when the history is not clear what the child could have possibly consumed. So chelation therapy with deferoxamine is what we can give, and it is not easily available in Kerala, unfortunately. Not in all areas, at least in our area, we found it difficult when the last patient came in. It is quite easily available in Maharashtra and other countries where they have a higher load of thalassemia or wherever thalassemics or patients who have who are being treated regularly with transfusion dependent illnesses, there you will get it. But this will be the proper antidote for a particular. When do we stop it? It you stop it when acidosis or shock is resolved, or when the windrose color of the urine gets resolved. The color keeps on changing as the patient gets better. Once the urine is clear, which is usually 12 to 24 hours after the patient gets improving, you don't have to continue it. But in general, rule of thumb, you don't continue deferoxamine for more than 24 hours because there is a risk of ARDs of, of deferoxamine also. Coming to alcohol, hand sanitizers, beverages, and even mouthwashes, and very rarely a typical alcohol also can be consumed by the child. You suspect it when there is classical features in aroma, depressed sensorium, respiratory suppression, and even hypoglycemia. You can confirm with the serum level. The toxic dose is 1 to 2 ml per kg. What you should look out for is hypoglycemia, metabolic acidosis, and even ventilatory support at times in the severe cases might be needed. Again, coming back to the same slide, one slide all of you should have with you at all points are these numbers. You can directly call them, even if it is happening in a distant place, even if it is not happening in a hospital, you can definitely call these numbers and find out what you're supposed to do at home when you should rush to the hospital. And if the patient does come to the hospital, you can even document it on your file saying this case has been discussed with the National Poison Information Center, and this has been advised, and go ahead with the treatment. So this has been a very brief talk. What if you want a detailed talk? There's a beautiful talk on YouTube by Thangavelu sir, which is on common pediatric poisoning. You can definitely go through this. These are few of the articles you can go on, which will give you a little bit more detail regarding naphthalene, kerosene camphor, and also caustic ingestion. If there are any questions, I would love to take it.
Thank you, Jijo. That was an excellent talk. I request Purushottam sir to give his valuable input. Sir.
It was a wonderful coverage in the limited time. Jijo, it's a vast topic, and all the physicians and the pediatricians will have a lot of stories, lot of experience to share. So, in such a short time,
so we would love to hear from you regarding your experience of a few cases of poisoning, sir.
Oh, lot of it over the years. So actually, I have a request to Gobi and Shimi, why house agents are not coming to this? Are they going behind the entrance and MCQ mode only? And our aim is to give some practical tips and that they are not accepting, I think. So should we include at the end of a talk a few of the MCQs based on the topic so that just to attract them? That's a suggestion, maybe in the coming thing. My experience from the period of 70s student period, and now there's a lot of change in the poisoning scenario because of the availability. At that time, of course, we didn't include two major aspects. Envenomation we didn't touch on, and we didn't touch on the plant poisoning. So just chemical poisoning only we highlighted today. So at that time, all those plant poisoning and envenomation were the most important ones and killing. Of course, the snake bite envenomation is even now killing people, but less number. The chemical poisoning, we are restricting today's topic basically on the chemical poisoning. There again, in the earlier days, the spectrum of problems, the iron poisoning was much higher in number at that time, but nowadays we rarely see iron poisoning. Maybe because the tablets they are not taking. I don't know why they actually in the initial years when the WIPS was introduced, and even before this, the color attracting and lot many cases of iron poisonings were there. And the one thing is the rat poisoning. At that initial years of my student and PG period, it was not that harmful. The phosphate, the dark one, oral, not much of a mortality. And later in 90s, I had the first instance of the ratol. One of the kid by mistake, it was came in the same the toothpaste like, just introduced into the mouth, and mother noticed immediately it was taken care of, but the child died. That is the first experience. It was very dangerous thing. And after that, we had a more and more number of cases. They are utilizing this for poisoning of one family committed poison. 4 or 5 members from Guruvayur. All these are due to this thing. Nowadays, I think the potential of the ratol and all are not that high. Still, once in a while, you are getting that poisoning. The other few points, this thing, camphor. In Trivandrum, there was a Vaidya who were using Mullali Thailam, where the camphor was producing seizures frequently. That camphor, and that was in 90s. The family Thailam, that was for asthma, and later convulsions were so common with that consumption. And one thing you said about the naphthalene balls producing methemoglobinemia. We had a few cases of dapsone poisoning in 90s. Dapsone available in 25 milligram, 50, and different strengths, and even small dose, maybe 50 milligram one tablet will be causing poisoning, and very difficult to detect them. Highly irritable child, there won't be any foci. Only thing is the color, a little bit different. It's not actual cyanosis. And if you are not taking the history may not be forthcoming because it is leprosy track. So there is a stigma. So in 90s again, we had a few cases. And at that time, we in Trichu, we made a methylene blue out of the lab chemical. We dissolved it, 1 to 2 milligram per kg of this thing, made a solution and gave it at that time. It was IV. Nowadays, it's not possible, but it's available now. So legal problems are all possible now if you use it, but it is available now, methylene blue. So when very simple test is, you take the blood and blood, one drop on a filter paper and control with another paper, one drop. So one drop from this patient and another drop from another patient, it will be different.
Can you switch off the TV? I can't talk.
Can you hear?
I can hear you. I can hear you.
Yes, sir. Yes, sir.
Okay.
We can hear.
Okay. So simple filter paper, one drop will be highlighting that methemoglobinemia, and dapsone poisoning, methylene blue is the answer. So at that time, it was not available for a parenteral injection. We made it at that time. Dr. One of the house agents, one point I wanted to highlight here is in 90s, this was boldly prepared and administered by one of the house agents, Dr. Sudhin in Thrissur. And actually, he is the pediatrician in UK now. He is the authority on the cooling for HI. So he did that. We were MOs, but he took the interest in, and he reported also that. So after that, we got this thing, but we got the methylene blue from outside. Now it's available here also. So a few of the MCQ questions which will be useful for you. The antidote list is a very useful for MCQ. And few other points, the ECG changes in few of the poisoning will be useful. Another one is an ABG, which may be useful in a few of the poisoning, like metabolic acidosis with respiratory alkalosis. Where will you get? In ECG, where will you get the broadening of the QRS complex like that? And another one, priapism, we'll be getting in envenomation with the scorpion, and rarely in the Russell's viper bite. So that's all MCQ points, but practically also useful points. I think we'll have their questions and we'll answer, I think.
Yes, sir. Few of the questions was MLC. Gopi has rightly said MLC has to be made even if it is not, even if they say it is accidental, it has to be made for our own safety. Safe to admit and observe any case of poison in a peripheral hospital without an ICU for observation. It cannot be safe unless you're absolutely sure what the amount is taken and what the patient is taken. So there's always a risk when you're keeping it in a peripheral hospital. But that being said, if the patient has to travel for so many hours for the next hospital, you can always tell them these are the expected complications and keep them till you are able to transport the patient safely. Again, at all points, it is always safer to talk with the poison center and take their advice also regarding what is the usual trend and how and when the complications will come. It might not be present when you're seeing the patient at that particular point because poisons will take time to act.
It's
That
like
is all the question.
yeah, like
One point about the kerosene poisoning, all the stages and the complications you mentioned. When you are getting a kerosene smell, don't think that it is kerosene only. Always look at the pupils and pulse rate, because organophosphorus poisoning will have the kerosene smell. So you may miss that. The simplest clue is the pupil size and the bradycardia, which are uncommon, which are to be treatable, eminently treatable. Regarding the plant poisoning, again, recently we had the early, and in my period of PG and 80s and 90s, in Alleppey and Thrissur, many cases of this odolam poisoning entirely, producing cardiac complications, hyperkalemia situations and cardiac complications, requiring pacing and all. So nowadays that also is coming, but the early poisoning recently which happened is important.
That's all the questions, sir.
so
Gopi?
One more thing is in a always a documentation is very much important because you never know when the patient will collapse. So always a better, so we have to document, and it's always better like in places like Kerala where you have access to hospitals. It's better not to keep in a periphery where because you may not have time to transfer the patient, then you may have an MLCs on your head, and on top of that you may have to face the relatives wrath and all that issues starts coming.
And
So
monitoring becomes difficult also. When you're trying to look at
monitoring.
child, monitoring becomes very difficult.
Yeah. And unless and until you don't have that facilities, it's better not to take a risk. Not worth it.
In the initial thing, the focused history after this ABC and stabilization, focus history, Jijo point out that try to get the history of somebody in the household or neighborhood taking, especially antipsychotic medications, anti-seizure medications, because the diseases with some stigma are likely to be missed. So maybe they'll tell about the paracetamol, some other drugs, but they won't be revealing the antipsychotic drugs. So the why it is so important is few of these antipsychotic drugs may not be the drug of choice which you use for usual treatment may do harm, like your phenothiazine poisoning, anticonvulsant. Few of the anticonvulsants can be dangerous. The dilantin sodium may not be the right choice for a few of the toxicities. That is very important.
And one of the common things which we get is oral hypoglycemic diabetic drugs also children can take and come in with hypoglycemia. Another message is to always send the wash which you are giving in all encephalopathy patients, keep it because that in itself could be an accidental poison and patient can be presenting as AES also. Those are the two practical points which we can advise.
Over the years, I said what was changing in 70s, 80s, and 90s. Something which was unheard of was the button batteries. Now it is so common, the button battery and the gel which is swelling. So, and magnets. The types of toys the kids are now getting, we can't imagine in 70s, 80s, and 90s. Now, button batteries for all the toys they are getting, many types of magnets they are getting, and the gels and all. So, out of this thing, very dangerous one is this button batteries. So, you need to keep that point always in your mind, Strider child. Again, one point, you take an X-ray, you see a coin. And if it is not producing stridor, you will wait. But very, very important, there are certain simple clues in the X-ray itself. Looking at the side view, that will be different from a coin. So, very important to recognize this thing because even a few hours of staying there can lead to corrosion. Jijo was pointing out it can corrode into the aorta and sudden death also is possible. So, always keep this point in mind.
So we had a case, the patient came with history of possible button battery ingestion. An X-ray abdomen was taken and nothing was seen and was assumed the child had not taken. And then later the child started having respiratory problems. Then it was found the battery was actually stuck in the throat and the child required intubation because child had airway problems. After intubation, repeat X-ray was done, looking at the side position of the ET tube. That is when the button battery was found to be on the top. I mean, it was at the site of where the ET was introduced. So then all emergency, everything happened. The child was settled, but like rightly said, after the child got settled, the child had also the button battery was sitting there for too long. Erosion happened and the child bled into the cavity. Fortunately, it happened in the morning. It was an immediate cardiothoracic surgery, took them up. The child survived, but it was a very unexpected, rare, acute complication where the child immediately crashed. So that is something which, so nowadays when we say always take an X-ray of both abdomen and chest, even if you're suspecting the button battery to be only in the stomach, it can even be stuck through the passage also. So it is better safer to take an X-ray of both the chest and abdomen when you have a history of button battery, sir.
Button battery, initially, there was a recommendation of giving honey. After taking button battery, you give the honey and that will prevent corrosion. But there are different opinion about this thing. Something without delay, it will be sent to for the surgeon. It better to take it out. One interesting story in the 90s when I was in Trivandrum, one 14-year-old boy was bought with reddish discoloration of urine, difficulty in swallowing and all. So nothing was obvious. There was a this thing bleeding from the aspirator, and we consider the possibility of connective tissue disorders, SLE and all, peripheral smears or hemolysis. And 1 or 2 days later, one of his relatives was a police constable. He came and asked him again and again, and then only he revealed he was having some trouble. He was conducting some financial thing among the students, and there was some problem, and he took formic acid, which kept for the rubber thing, and that produced the corrosive injury and the renal toxicity, hemolysis and all. So by the time we recognized this thing, that was already delayed, and we couldn't do anything. He was there for one and a half months in that SIT hospital. He was referred to surgeon, and the esophagus and all was all melted and joined together. So gastrostomy was fed like that. He emaciated. He died after 1.5 years.
The morbidity after all corrosives is very bad.
Very bad.
So if the patient survives, it is a long, very morbid condition, especially the ones who are attempting. It is accidental, usually it is not so bad because the amount is less. But the moment it is a poisoning, it is attempted suicide because of the volume. If the patient survives, it is a very tough course ahead. So a few of the questions, Datura poisoning. I have not had any personal experience with Datura poisoning, but from literature, what is said is it can cause dry mouth, and your GI motility reduces. Also, Datura can cause speech to be difficult to speech, and for speech and swallowing is your classical symptoms. Urinary retention is possible, and your treatment classically the antidote has to be physostigmine, which is your cholinesterase inhibitor. But this is all theory, and I don't have any experience with Datura. So what we study in forensic and what the scientific this one says. Antihypertensive poisoning also, because it is available in the house, it does happen. And as being an hypertensive, the patient can have hypotension. It has to be managed till the drug clears. Multivitamins or vitamin syrup again usually doesn't cause much harm unless you can have your pseudo tumor cerebri with your vitamin A or hypervitaminosis A. So that is one of the common things which we can get with regular dosage also. Other than that, there's not much of a problem. All washes, if it is given within 1 hour of ingestion, unless it is a caustic or anything which can cause a burn, is effective. Anything beyond 1 hour, the effectiveness is doubtful. It's the general consensus.
About use a last comment, vitamin A. Vitamin A, important thing is that 1 ml contains 1 lakh. Initially, the delivery was, there was a spoon, two side. One side was 1 ml, the other side 2 ml. So babies will be getting 1 ml at 10 months and beyond that 2 ml. So sometimes they'll be giving it to a 5 ml teaspoon. 5 ml means 5 lakhs. They will come with vomiting, irritable, and the fontanelle will be
Bulging fontanelle.
But none of them produce more of problems. After a few hours or days, child will be all right.
Extraperitoneal symptoms with domperidone also is something which we actually get, even though it is not typically poisoning, but that is also something children can come in with.
Earlier we used to have that perino.
But nowadays that also is. Previously, few preparations containing the antiemetic complication leading to extrapyramidal syndromes are very high. That it is not less common nowadays. Regarding the one point I wanted to regarding the atropine poisoning, datura, plant the seed consumption producing these complications are less common, but during the organophosphorus poisoning, we'll be giving atropine. The dose of atropine when you are giving for a poisoning will be very high dose. So it's not the one ambule form. When you are giving the organophosphorus poisoning, it will be in the adult medicine, it's in the 100 ml, you are giving in IV. So that will be the dosage. It will be, I think, 4 mg, 0.04. Instead of 0.04 or 0.05 you are using for usual dose, it will be 10 times every 20 minutes. And that high dose or an infusion of atropine will be giving. And after a few days, you will have the madness for lasting for few days. The hyperpyrexia, madness, mad as a hen.
Hat. Mad
Okay.
as that.
Like that. Dry as a and they are not no sweating. No sweating. And hyperpyrexia and the madness, all those things are a combination, and that you will get the typical atropine datura type of poisoning during the organophosphorus poison.
Blind as a bat, mad as a hatter, hot as a desert, dry as a bone, dilated pupils, red as a beet, tachycardia, absent bowel sounds, tremors and grabbing invisible objects. And he called this toxidromes.
Okay, that will be there for a few days. In the organophosphorus poisoning treatment, it should be kept for at least 1 week, because there can be a late absorption and complications. One of the point, another one, Jiju already mentioned, there is a possibility of late onset paralysis, organophosphorus leading into Guillain-Barré-like situation also. So both reasons, late onset cardiac arrhythmias and late onset neurological problems, they should be kept there in the ward. And during this period, they'll be having the problems of atropine. That won't kill them anyway.
Cod liver oil capsules, I had to look up literature regarding whether it causes poisoning.
Poisoning not common, because during my early period, this was so common, the Gulf people will be bringing it, but the concentration is not that high. The vitamin A content in those things will be somewhere around 2,500 or something like that. So the poisoning with that is not that common. So possibility is not acute poisoning, not high, but they will be continuing to take it for longer duration. So we all talk about the chronic poisoning, but this is some situations where they'll be taking it for a very long period. So rarely only we see vitamin D poisoning and vitamin A poisoning, but we had a few cases of vitamin D poisoning. That's not earlier, almost 4 or 5 years back. One was because Jiju already pointed out the variation in the dosage of the paracetamol.
Concentration.
Just like that, vitamin D is available in 200, 400, 800, or even 1,000 unit in 1 ml. And
now vitamin D3 araquanidol nanoanol comes in 60,000 in 5 ml. It's coming such high, 5 ml 60,000 high. So that also, even though it's only one bottle, that also in a smaller child, if taken accidentally, can cause hypervitaminosis also.
One kid was 4 months. She was brought by the mother with a polyuria and some breathing problem. We investigated. It was 4 ml per kg per hour. Polyuria was there, and the dehydrated look and a little bit of acidotic breathing. We worked up the case. RFT was deranged, and the ABG was showing acidosis. Ultrasound and X-ray showed there was a calcification of the renal. And on close questioning, we consider all the possibilities of inherited renal disorders and all. On close questioning, what she was getting was this vitamin drops 800 or 400 international unit per ml and continuing from the newborn period onwards. So that was by mistake. The pharmacist was giving it. Some other brand was. So very important when you are prescribing vitamins, very likely that they'll get some vitamins. Especially vitamin having high dose, very, very important.
So some vitamins now that all D3 they have two drops. One drop is 400 international units. So invariably you'll end up with a poisoning when you have the 2 drops. Okay, now if we don't have any questions, Simi, can we wind up?
Yeah, I think so. We can wind up. We had also very good discussion also. I think because all the common poisonings were talked about by Purushothaman sir also.
So I take this opportunity to thank Simi and our chairperson Johnny. I thank Dr. Jijo for his excellent talk and Vinu Kotan for introducing him. As usual, Purushottam sir, your inputs were very valuable to us. It's always a pleasure to hear you talk.
Absolutely. It is
Join
always a
us,
learning experience to have Purushottam
Yes.
sir with us.
Yes, sir. Really, it's a really. Thank you very much, sir, for joining us, and thank you all the participants. Anyway, thank you. Jai Hind, Jai AP, and good night.
Good night.
Good night, sir.